molecular basis of radioactive iodine theranostics. There are several definitions of theranostics. The definition that I prefer is determination of molecular target or mechanism using a diagnostic method or technology for a specific molecular, radiomolecular, or surgical interventional treatment. Radioactive iodine imaging and therapy is the epitome of theranostics. The whole saga starts in 1936, actually, at Harvard Medical School, where a question was posed by Dr. Saul Hertz if anyone could make iodine radioactive. The answer was yes, and the studies start right away. In 1937, they acquire a little cyclotron to produce I-128 with a half-life of 25 minutes and daily production of which was only 50 microcuries. The first physiologic studies on rabbits were performed under these circumstances. Are you showing your screen? The first patient was treated in 1941, March 31st, 1941, by Dr. Hertz. Dr. Hertz, after this publication on May 3rd, 1941, receives an award and becomes a young Turk. He was inducted to be a member of Society of Clinical Investigation. And the members of this society were called Young Turks because they all were innovative young people. Interestingly enough, when you hit the age of 40, you had to be released from your membership so that you can stay young. The use of radioactive iodine treatment for thyroid cancer idea starts as early as 1937. In a brief communication in 1946, Dr. Hertz describes the story in these words. At the outset of the above experiments in 1937, it was thought that there might be equally promising therapeutic possibilities in the treatment of carcinoma of the thyroid. Preliminary tests on 2 patients with cancer of the thyroid were reported in 1942 in a John and Mary Markle Fund report. Tracer studies in these 2 patients indicated that in the types of cancer of the thyroid which were present, adenocarcinoma, there was no increased uptake of radioactive iodine over that of adjacent normal thyroid tissue. It was also demonstrated that metastases in the adjacent nodes were not receptive to radioactive iodine. He goes on to say that they pointed out, therefore, that the cancer cells were biologically quite different from the normal and hyperplastic thyroid cells, where radioactive iodine was extremely successful. This was the first note that actually expressing the knowledge of cancer having depressed function in terms of radioactive iodine handling. This is the cover of the title of the paper he presented to in Bulletin of the New England Medical Center, October 1946. He says, certain tumor types do have limited capacity to retain radioactive iodine. So he is very skeptical in the at that time, even in 1946. They performed a number of studies with Dr. Rawson of Harvard at the time. They did multiple autoradiographic studies. This histologic section shows a papillary thyroid carcinoma and an adjacent normal thyroid tissue. Autoradiography of this shows intense uptake in the surrounding tissue, but essentially nothing in the papillary thyroid cancer. This is another example of what was called at the time a microfollicular carcinoma showing no uptake. I am not sure if there is an issue with sharing the screen.
Yeah, we're not seeing it.
Okay, I will fix that. I apologize for this. I apologize for this morning glitch. First treatment of radioactive iodine treatment for thyroid cancer was given in 1943. It was a combination of I-130 and I-131. It was given in multiple fractions over several months, and it was published as a case report in JAMA in 1946 December. It didn't make a big impact until the news appeared in Life magazine on October 31st, 1949. The patient was a middle-aged man who presented with hyperthyroidism and cachexia. After a lengthy investigations, including his basal metabolic rate, he received a tracer dose of radioactive iodine, which showed intense uptake in what they detected as metastatic disease by standard radiologic methods, plain X-rays. The patient subsequently received radioactive iodine, a total of which reaches to the number of 102 millicuries, and it was given between May and August. The fractions like 2 millicuries to 17 millicuries. He later on underwent a surgical resection of a metastatic lesion in the skull, which shows nicely what the response to radioactive iodine treatment was. Obviously, this made a major impact in the medical community, and the treatment was embraced from that moment on. In the meantime, the concern raised by Dr. Hertz and the studies conducted at Harvard Medical, and then later on at Memorial Sloan Kettering, using autoradiography, indicated these interesting findings, where autoradiographic studies showed clearly that normal thyroid had a very intense radioactive iodine uptake, but yet particularly papillary thyroid cancers, but all other thyroid cancers have limited iodine uptake. In the primary lesions, papillary cancers showed about 11% and overall 26% radioactive iodine uptake. And this uptake was significantly lower than the normal thyroid uptake. Again, the studies performed by Dr. Rawson at Harvard Medical indicated that the only way to increase radioactive iodine uptake in the metastatic lesions was to perform a total thyroidectomy. And this was clearly stated in a classic textbook of Dr. Beerwaltes in 1957. And then, since then, it became a standard dictum that total thyroidectomy is the only measure proved to increase radioactive iodine uptake by metastases. This is the brief timeline for early events in radioactive iodine theranostics that I already told you. This classic textbook by Dr. Beerwaltes on this chapter lists the following. Less than 50% of thyroid cancers pick up measurable amounts of radioactive iodine. The tumor with the highest functional activity reported 40% of the concentrating ability. All tumors have been reported to have radioactive iodine uptake less than 3%. And again, it was concluded that total thyroidectomy was the only measure. That's why this historical background, I think, gives us a better understanding of why understanding the concept of theranostics in the context of radioactive iodine is extremely important. The physiology, pathophysiology, and oncopathophysiology of radioactive iodine theranostics is important to understand to better appreciate and better utilize the theranostic power of radioactive iodine. There are three major mechanisms and pathways that need to be discussed for radioactive iodine theranostics. One is iodine pathway itself. The second pathway is TSH and thyroid-specific transcription factors pathway. And the third pathway is MAP kinase, PI3K, oncogenic pathways. MAP kinase pathway is most relevant for I-131 theranostics, and we'll go through this momentarily. Radioactive iodine, as picked up by thyroid cells using sodium iodide importer SLC5A5, it's transported into the lumen through this, again, so-called pendrin SLC26A4, and it's immediately incorporated, organified into the thyroglobulin, which is the main constituent of the colloid. This organification requires DUOX2 and DUOX1 reaction, which generates peroxidase, which is required for TPO action. And then mono and diiodothyronine and small amount of T3, T4 are then returned into the thyroid follicle. And as needed, T4 is released. Within 4 hours of administration of radioactive iodine, 90% of the inorganic iodine is organified. Part of the organified T4 iodine is dehalogenated and recycled, and the remaining T4, T3 is released into the circulation. Now, this iodine kinetics create a biphasic kinetics curve. This is the first upslope curve. This curve represents the uptake, and it's as fast as 4 hours, and it represents all these steps: NIS, pendrin, TPO, DUOX enzymes. These are all involved in the uptake phase of radioactive iodine. The clearance phase includes influx of T4, T3, and dehalogenization and recycling of the inorganic iodine and release of T4 in the circulation. This takes more than 96 hours. The area under the curve is known as cumulated activity. And cumulated activity is what determines the theranostic output. The higher the cumulated activity, higher the therapeutic efficacy of the radioactive iodine, and also diagnostic power as well. This is, I think, the most important piece. Any enzymatic dysfunction resulting from the oncogenic progression would alter this curve and accumulated activity, thus altering the theranostic power of radioactive iodine. The TSH and thyroid transcription factors relationship, when TSH is attached to the receptor, it eventually stimulates, initiates the thyroglobulin, TPO, and NIS transcription in the nucleus. TSH also is instrumental in relocating NIS transcripted protein onto the apical phase apical surface of the cell where it functions. In the absence of TSH, this translocation doesn't happen and radioactive iodine can't come in. These three thyroid-specific transcription factors, TPO, thyroglobulin, NIS, are the major catalyzers or transcriptors of TPO and thyroglobulin, as well as NIS. Altogether, they determine the uptake phase of our curve. Now, this is the mutational profile of thyroid cancer. Thyroid cancer, like all the other cancers, is the disease of genome. There is an oncogenic stimulus, which is a mutation, typically, most of the times, a mutation in one of the oncogenes. And this oncogene is called the driver mutation. Starting with the driver mutation, lots of additional genomic events add on to the picture. One leads to another, and then the whole picture becomes very complicated. Additional mutations, involvement of microRNAs, methylation of DNA, deacetylation, epigenomic changes. The genome becomes more unstable as these genomic events accumulate. And finally, the complex picture of cancer, in our case, thyroid cancer, solidifies. Thyroid cancer, compared to other cancers, have the lowest mutational profile, which makes it a very good model to study. Basically, majority of the patients have BRAF mutation, and another second large group have RAS mutations. These mutations are, RAS and BRAF are the small molecules as part of the signal transduction inside the cells, thyroid cells, leading to cell cycle activation and dedifferentiation of the thyroid cancer. RAS mutation is a marker of neoplasia. Benign neoplasia, adenomas, NIFTP may be positive for RAS. It's an early stage of oncogenic progression. If left alone, this could progress into follicular thyroid cancer or follicular variant of papillary thyroid cancer. BRAF, on the other hand, is exclusively a marker for papillary thyroid cancer. When detected in thyroid nodules, it indicates thyroid cancer. Looking at the progression of thyroid cancer, first of all, 84% of all cancers in the thyroid are papillary thyroid cancers. Then in the order of frequency, follicular, medullary, poorly differentiated, anaplastic, Hürtel cell types, and others. In 84% of the cases, it starts with 84% is the papillary cancer. 60% of this 84 is initiated by BRAF mutations. 13% is initiated with RAS mutations. 7% is initiated with RET mutations. Then there are additional mutations added on. And then the papillary thyroid cancer starts dedifferentiating morphologically and functionally towards poorly differentiated thyroid cancers and anaplastic thyroid cancers. Every additional genomic change leads further destabilization of the genome, which invites more genomic changes. And this is a process towards lesser differentiated forms of thyroid cancer. Luckily, in 90% of the cases, this progression is rather slow. That's where the term indolent comes from for describing papillary thyroid carcinoma. In 10 to 15% of thyroid cancers, papillary thyroid cancers, this transformation is very fast. In very small fraction of the patients, like approximately 2%, anaplastic thyroid cancers occur within matters of less than 6 months. This slide shows the steps of signal transduction. The tyrosine kinase receptor, when activated, activates RAS, BRAF, BRAF activates MAC, MAC activates ERK. I'm going to go through these step by step. This system activates transcription factors, a number of transcription factors in the nucleus, and it translates into cell cycle activation as well as thyroid cell differentiation. Now, showing with animation, RAS activation leads to BRAF, that leads to MAC. MAC stimulates ERK. ERK translocates into the nucleus and first activates these pluripotent transcription factors. Then they in turn activate the cell cycles. From our theranostic purposes, what ERK does is, by shutting off the transcription factors, first non-specific, then specific to thyroid cancer, shuts off the thyroid-specific transcription factors. They altogether shut off the expression of all the enzymes, all the molecules, at least most of them to a significant degree, expression of transport systems, which suppresses the iodine handling in the thyroid cancer cell. This figure is from a publication in 2014, which I refer as a seminal paper in thyroid cancer genomics. The integrated genomic analysis of papillary thyroid carcinoma. This is performed on 490 patients, more than 490 patients, close to 500. Most extensive analysis of papillary thyroid carcinoma. In the second row, you see the common mutations leading to thyroid cancer. The first upper row, you can, by all practical purposes, for functional or morphologic associations, there is BRAF-like tumors and there's RAS-like tumors. These two tumor types have distinct features in terms of histology. Going from blue to red is a follicular differentiation. As the tumors are more RAS-like type, their morphologic appearance include more of the follicles than in the BRAF-like. Most of the, or the dominant picture is papillary structures and so well-known orphan Annie nuclear features. Follicular fraction is also dominant in RAS-like tumors. Most interestingly, the differentiation score, which is a combined numerical expression of thyroid differentiation, goes from blue to red, red being the highest differentiation score being +2 and lowest differentiation score being -4. As you see, BRAF-like tumors have a more depressed differentiation score as opposed to RAS tumors having a higher differentiation score. The link brings back the memory of this, the first case treated with radioactive iodine, the patient presenting with hyperthyroidism, hyperfunctioning metastatic disease. Obviously, it belongs to this RAS-like group with very high differentiation score, and thus was treated very successfully. This slide shows the thyroid differentiation score versus other features. On the third row, ERK signature from high to low corresponds to low to high thyroid enzyme and transporter expressions. Green is low, red is high or normal, And on this side, on the very right side, is the normal thyroid expression transcriptomic profile of all the enzymes that make up the thyroid differentiation score. They inversely correlate. The transcriptive activity is inversely correlated with the ERK signature. And the BRAF-RAS score is also proportionally correlated with the thyroid differentiation score. What's most important here is the clinical risk stratification. And the clinical risk stratification is when the clinical risk score is higher, those patients have lower thyroid differentiation score, which has a very important impact on clinical decision-making, sometimes wrongful, and selecting patients for clinical trials. We'll discuss this in length later on. The existing paradigm of treating high-risk patients with radioactive iodine and total thyroidectomy needs to be rethought in lieu of these findings that high-risk patients, in fact, have low thyroid differentiation scores. So, summing up this physiologic observations, TDS is a quantitative molecular measure of functional differentiation or the differentiation of thyroid cancers. TDS is inversely correlated with MAP kinase ERK output. TDS is negatively correlated with BRAF score, but positively correlated with RAS score. The theranostic performance of radioactive iodine is dependent on TDS. Tumors with low TDS, as I call them, are radioactive iodine indifferent. They lack the ability to handle radioactive iodine like normal thyroid can do. MAP kinase and ERK output can be downregulated, can be modulated using special tyrosine kinase inhibitors to improve thyroid differentiation score. There are lots of clinical trials and few approved tyrosine kinase inhibitors that we're going to talk about in the second half of our session this morning. At this point, I'm going to stop and turn the podium to Dr. Van Nostrand